Thanks for that introduction, Helen. I apologize that I barely have a voice, but I have brought my own culinary medicine with me. I have some honey and lemon, so we'll see if it can get me through. If you can't hear me, just raise your hand and I'll try like 3 microphones or something. So I'm really excited today, whether you can tell it or not by my voice, to talk to you about culinary medicine and some of the basics that have been applied in medical education at a variety of levels, mainly in the US, although some of these examples do travel internationally and are spreading quite rapidly. So I won't go into great detail about what I do, but you can tell I do a number of things, and I wear a number of different hats, including a chef's hat. And most pertinent today, I'm the course director for the Teaching Kitchen elective for medical students at Stanford, and then I also practice internal medicine, primary care, and obesity medicine, primarily for a variety of different types of underserved patients. So I also think that it's really important to think of creative ways to apply culinary medicine to make sure that we reach underserved patients, and I haven't necessarily gone into all the details of how I do that, but I'm happy to take questions about that and also some of the things that Anna Maria pointed out in terms of, what are some different models, how we arrange culinary medicine at institutions, and that's also in the manuscript. But I wanted to really keep it short and keep it to the 30 minutes so that we could have more of a discussion. So on the proverbial menu today is, I'll first just define culinary medicine for anyone that doesn't know what that is. And I'll talk to you a bit about why doctors should learn culinary medicine. I put / nutrition. They're not the same thing, obviously, but there is a significant amount of overlap. Then I'll give some examples of culinary medicine at each level of medical education in the US. I'll highlight our Teaching Kitchen elective at Stanford. And then I always end with a slide of just quick tips, which are basically just a reflection of what I think most of the speakers have already told you should be eating, so not news there. So the definition I like best for culinary medicine is an evidence-based field in medicine that blends the art of food and cooking with the science of medicine. And that was written by John LaPuma, one of the early chef MDs out there in 2008. A more technical definition that gets used a little more widely was created at Tulane, the only location that has an actual center for culinary medicine in the US, and that's the utilization of the combination of nutrition and culinary knowledge and skills to assist patients in achieving and maintaining health. All right, and I feel that Martin possibly already listed most of these things on the slide, so I'll go through them quickly, but the reason that it is important for physicians to learn not just culinary medicine, or not just nutrition, but also culinary medicine, is that diet is a key contributor to obesity and has been identified as the single most important risk factor for morbidity and mortality in the US. And I imagine that it's similarly an important risk factor for morbidity and mortality in all of the countries that you're all visiting from or listening from. National surveys in the US suggest that the majority of patients regard physicians as very credible sources of nutrition information. But when you ask those physicians, they feel inadequately trained, not surprising based on everything we've heard thus far, about how to advise patients on food and eating behaviors. And then one thing that we haven't discussed quite as much is that this is really important for personal health. And there's literally an epidemic of burnout among physicians in the US, and I'd love to hear if it's similar in other countries. But one of the key factors in preventing burnout is good self-care. And so this wouldn't just be nutrition, but nutrition is a key component of this. And if physicians don't know what appropriate nutrition is or how to counsel patients on it, most of them also don't know the foods that they should be eating. And they're more likely to burn out. And then the added bonus of having physicians actually practicing what they should be preaching is that they'll be more likely to advise patients on any health behaviors they have, whether that's nutrition, physical activity, good sleep habits, etc. And this is a very small little study, but I always like to include medical student work in presentations that I do. But this highlights some key points that I've seen in much bigger studies elsewhere. But this recently graduated medical student did a mixed method study of physician perspectives on nutritional curricular content in the Bay Area of California, so not just at Stanford. And she interviewed medical generalists and specialists in all of these different fields and tried to get some variety of inpatient and outpatient perspective, as well as adult and pediatric practitioners. Excuse me. So what she got when she asked about basically self-reported assessment of what these physicians had learned in medical school about nutrition, 47% of them felt that they got zero nutrition education, and the majority of the remainder felt that what they got was inadequate. And of those qualitative comments that came back for those that said they had inadequate education, they felt that there was just too much focus on biochemistry and micronutrient deficiencies. There wasn't enough content relevant to current clinical practice, and they really, over and over again had said they wish they had more direct clinical application and primarily practice, so they felt more comfortable jumping in and counseling patients. And so I really feel that nutrition education is a missed opportunity for many of the reasons we've heard. It focuses on important things, but just doesn't go far enough. There are too few hours spent, as we've heard. And one thing that has been said a little bit less frequently, or possibly not at all, in these sessions is that it's a bit strong to say it's at the wrong place in the curriculum. It should be at all parts of the curriculum. But we really focus on teaching nutrition in the first 1 to 2 years. And for a lot of the reasons that Corinne has pointed out, it's much more complicated to get into the intensive clinical part of education. But you have a lot of medical students who don't realize nutrition is important in the first 2 years, but then go on per what we hear over and over again from a lot of the students I teach, that they suddenly realize that many of their patients have diet-related diseases, actually almost all of them, if you include obesity, which is one of the key ones, and diabetes. But they then have this hunger to learn it, and then they don't know who to turn to. And there's also a focus on making sure you get the right nutrients. So there's a lot of talk of get fiber, get vitamin C, get zinc, get iron. But most people then leave medical school not knowing what foods those things are in. And no one sits down to dinner and says, I'm going to have some fiber with a side of vitamin C and some folate. They say, I'm going to have a salad with some oranges, things like that. And although I know that this is becoming more and more in vogue to include motivational interviewing and coaching, there needs to be a lot more of it. We're just not great at the behavior change aspect of patient counseling about anything, but especially nutrition, for the reasons we've talked about. And so I like to not just have a lot of wordy slides, but show this in a picture. So culinary medicine versus traditional nutrition education may be the difference between saying, you have this heme molecule with iron in the middle of it on your left, and you might talk about how it got there, and that go ahead and just eat a lot of red meat because that's the best way to get it, and there's a huge epidemic of iron deficiency in the world. But in an environment, especially in the U.S., where we tend to have a lot of overnutrition, not necessarily in iron, but a lot of other nutrients and calories, then it may be better to say, okay, let's focus on some healthier sources of iron, which would be vegetables, non-heme sources of iron potentially, but they're really hard to absorb. So how can we use cooking and culinary medicine to then make sure that we're actually absorbing some of those things? So this is a kale salad with figs, which both have iron, and then there's a citrus dressing and pomegranate seeds, which are high in vitamin C, which would help absorb that. So that might be something that students would pick up on with a culinary medicine approach. So now I just want to highlight a few examples from each level of medical training in the U.S. So medical school, graduate medical education or residency, continuing medical education, which is for practicing physicians, and then a couple of other intensive or in-depth learning opportunities. So I know that Tulane has been listed on a few slides, but I hadn't heard anyone go into great detail about what are they actually teaching there, what are the students getting. I thought that might be of interest. So Tulane Medical School is in Louisiana, for those of you that don't know, in the southern part of the U.S., and they received a generous donation back in, say, about 2008 to create a center for culinary medicine. And they have released their curriculum and started licensing it to a number of medical schools, 39 as of April this year, to use. And they're only licensing part of their curriculum for the most part. But This is a 28-hour elective that's broken up into 8 modules and has a large hands-on teaching kitchen component. They highlight Mediterranean diet principles, and they list in their papers nutrition counseling, although when you actually look at what they do, I'm not sure where exactly that comes in. It's a little unclear. But they do also, everything I've listed thus far is for the first and second year medical students. For the third year medical students, they can opt to have also additional disease-specific interdisciplinary seminars. And then fourth years can elect to do a 4-week away rotation where they partly rotate at a hospital in Rhode Island in the Northeast United States, and then part of the time work side by side with culinary students at Johnson & Wales Culinary School, also in Rhode Island. And then students at any level, first through fourth year, can participate in and even lead community cooking classes. And for these, they recruit low-income patients from an urban underserved area near the university and lead them in hands-on cooking classes. And sometimes they have students from the culinary school rotating with them, so it would often be medical students, culinary school students, dietitians, and then patients. And so the 8-module series, as I mentioned, is for the first 2 years. And then how that is actually broken up, those 8 modules, is each one follows a similar pattern. There's a 30-minute video and quiz portion, and the quiz is really to get at what's the baseline knowledge level of the students going through the class. And then they have, before they get into the kitchen, they have their in-class portion, which is 3 hours in total. The first 45 minutes is an in-class discussion, primarily covering a lot of what they saw are knowledge gaps for the students based on their quiz responses. And then they do an hour and a half of hands-on cooking. Thanks for bearing with me. I'm going to get through this talk with my voice at the end, hopefully. Then they have 45 minutes of a meal where they discuss primarily board-style questions. And I imagine that may be where their patient counseling comes in. And then I'll highlight where it's similar and different compared with our teaching kitchen elective we have at Stanford. So I mentioned there are 39 schools that license the two-lane curriculum. We've created our own. And this, again, like most people have said at their institutions, is a labor of love. I didn't get paid to make this curriculum, but wrote an entire curriculum for this 1-quarter-long elective. And before I go into the details, I'm hopeful that this 1-minute video will play. Let's see, I have to go back. There we go. So they tested it, it would play. So now it's saying it's not available. Maybe we can work on it and come back to it. So, all right, well, we'll skip over it. I can give you the link to it. It's on YouTube, but it's just a 1-minute video of the students in the kitchen during the first session that we ran, which I think is more illustrative of what goes on in the kitchen than anything I'm going to share with you on PowerPoint slides. But, so the folks that I've worked with on this project are numerous, and the 3 listed on the top, myself, and then another chef MD, Julia Nordgren, who works in the Bay Area but is not at Stanford. And primarily, she works with pediatric patients with lipid disorders. I primarily see adult patients, so we're a great team. And then we don't actually have our own teaching kitchen on the medical school campus. There's a teaching kitchen on the undergrad campus at Stanford, which we have to rent out for quite a hefty fee each time we want to run this course. And so I have to spend a lot of time fundraising to be able to hold this. You can see that that's not a very sustainable model. So they are working on building a teaching kitchen at the medical school proper, which won't be done for a couple of years, but at least that's progress. And Chef David Ayat, who is wonderful, is the chef that runs the teaching kitchen on the undergrad campus, and so he participates very heavily with us in this course. And then I also work with the 3 faculty along the bottom, Maya Adam, lecturer in pediatrics, Christopher Gardner, an endowed chair and professor of medicine, his PhD is in nutrition at Stanford, and then Tracy Rydell, she's actually now an associate professor of family medicine, And the four of us work on all of the required content in the medical school curriculum, primarily in the first 2 years, though since Dr. Rydell runs the family medicine clinical rotations, they also do have a fair amount of nutrition in their family medicine rotation at Stanford. And so, as I mentioned, this is a quarter-long elective, but completely by chance, we also have 8 sessions. So I don't know if that's just the magic number that people that know about cooking and medical education come up with, and also a similar amount of time. We picked 2 hours just because it felt too burdensome to expect 3 hours in person at a time, and this has to run in the evenings because the students don't have any other elective time. So we do it from 6 to 8 p.m. We require 30 minutes of pre-work, and we don't do quizzes ahead of time, although I think it's a good idea. We do some videos primarily of a lot of the cooking techniques, some of the basic nutrition content that we'll go over in person, but a lot of it's just to get them ready so they don't have to spend so much time passively listening to us in the kitchen, and they can just jump in and get to work when they get there. And then the readings are primarily journal and other content related to the nutrition component. Then we do an hour and a half of hands-on cooking. And you certainly do not need 2 chef MDs and 1 chef to run this course. This is just a lot of people being really excited about the course. You could easily do this with no MD lead or an MD dietitian combo. And one thing that's unique about our course is that because we found through word of mouth that there are a lot of interested faculty around the Bay Area, around campus in this, that may or may not know anything about cooking or very much about nutrition, but think it's, some are experts, some just think it's important. But we have faculty from a variety of different specialties come just for 1 out of the 8 sessions, and they share directly with the students who are often first and second year students, since that's who has time to spend a quarter-long elective in the kitchen. They share how this is directly applicable to the patients that they're seeing in clinic. So we've had a heart surgeon, a cardiologist, a psychologist, obesity medicine specialist, basically you name it, they've been there. And we've also had a variety of chefs and dietitians come and join as well. And I will mention some of them know so little about cooking that if a student is absent, they'll just jump in and we'll teach them how to cook too, so they can both understand nutrition and cooking. So then after we've spent an hour and a half in the kitchen, the last 30 minutes of the session is spent in a dinner discussion, and that is pretty open-ended. We allow the students to ask, whatever they want. Often, I think what pulls them into the course is just they're self-interested in, what can they eat, what is an optimal diet for them, how can they be healthy, which goes back to my previous points. And I think it's a really good hook for students earlier on in medical school. I think they become a little more patient-focused as they move through and they're seeing more patients and not just studying on their own. But we do a lot of role plays, which for some of the introverted students puts them on the spot, but I've still had some of them tell me that a role play in front of everyone was still the thing that really made them feel confident about counseling patients. So we give them a prompt like the following one, and I'll explain our final potluck session in a minute, but here's the role play prompt that we give the students during a session where we talk about pasta. And I'll just go ahead and read it in case people can't see it very well, but we ask them to counsel a patient with obesity and diabetes about how they can include pasta in their diet in a healthy and tasty way. So I will emphasize that we don't just talk about healthy food, we talk about delicious food that happens to be healthy, and so we really approach it with the tasty, delicious, visually appealing message first, and that really pulls them in to then absorb the nutrition message. It seems to work a lot better than the other way around with, I think, everyone, not just students. And we ask them to try and make modifications to what this patient typically eats, which is a large plate of fettuccine Alfredo at least once a week. I think I picked the one that was from Cheesecake Factory, a big chain, and has just an obscene amount of saturated fat and sodium and carbohydrate for someone with diabetes. And so I was really impressed with some of the responses that they gave when I asked them to make at least 5 healthy changes, and that could include changing amounts, it could include changing any component of the meal, whether it be the pasta or something else. And so some of the responses included, something we've all heard a lot, which is just have a smaller plate. But some of the more creative ones were that they would encourage the patient to start making more things from scratch, and that I had asked them to actually describe in words how someone would do that, and they were able to do that in a simple and easy way. And they were able to identify that a lot of the processed foods, even if it isn't a fully prepared meal, is full of a lot of nutrients of concern. They also had spent some time experimenting with different ways that they could have creamy sauces that were made from things like cashews, so they had healthier fats. And they got to use a zucchini noodle maker, and they really loved making zucchini noodles, so that was a popular response. And then also trying some different high-protein noodles so that they just didn't have as many empty carbs. And they, of course, had made about 6 different pasta sauces in this session, so they offered up some of the other recipes that you didn't need necessarily a recipe for, but you could just throw things in a pot based on the instructions they gave and make something delicious. And because when I did this, I was actually a postdoc, which I'm done with now, the only way I could rationalize spending my time with this, and I'm glad it was the case, was to run this as a study. And so for the first session, we knew that there were enough people interested in the course that we could allow, and we explained to them that this was happening, allow more than twice as many students as would fit in the kitchen to enroll, and then we randomly allocated them to be students or be waitlist controls with the promise that if they were a control, they would get first dibs at taking the class the next time it was offered. And so we had a pretty extensive pre-class survey that covered attitudes, knowledge, and behavior about cooking, patient counseling, things of that nature. And then we had the 8-week class, and they had a very similar follow-up survey. And the first group of students that's finishing up, or that had finished up about 18 months ago, is getting ready to get a long-term follow-up survey to see if this has actually made any difference, not just that, as someone mentioned earlier today, study and then do it and then forget about it, but are they actually using it with themselves and their patients? So feel free to email me if you want to know the answer to that. But the students in the course for the first session that we ran, made a lot of significant improvements, and this is just a very preliminary analysis. I'm working on doing the analysis of all 3 classes that we've run to publish in a manuscript. But the students, compared with their own baseline, made significant improvements in using knife skills, basic cooking techniques like stir frying, roasting, making healthy soups and desserts. Personally, they said that they got in 5 to 9 servings of fruits and vegetables a day more often. They were better at eating healthy snacks and felt confident in planning balanced meals. And notably, the waitlist controls didn't improve in any of those items. So some of the questions on the survey were open-ended, and I really like to get both quantitative and qualitative data when I collect survey data. So I'm just sharing a pretty typical response I got from some of the students when asked how they thought that participating in a teaching kitchen course would help them with their current and future patients. And this particular second-year student said, "I feel more confident making delicious, healthy, and easy food with the constraints of time, budget, and resources. I can use my personal experience to talk to patients about how they can similarly enjoy home-cooked, healthy food and overcome whatever barriers they face." And so I thought, that's really powerful. I mean, that's really what we want people to get out of nutrition education, and hopefully also some mastery of the content, but this covers a lot of bases. So some of our next steps, as I mentioned, are fundraising to continue to run this course until we actually have a teaching kitchen on the medical school campus and get some institutional support for that. We'd also really love to use some, if we're able to get some more funding, to create some flipped classroom content. So more of the video content, put more of what we do in person in the kitchen into an exportable online content model, so that even if people can only do part of this at a different medical school, or they have someone that can teach cooking but they don't necessarily know the nutrition part, that there'll be enough resources available that they can pick and choose what they need to fill the gaps, so they could run something quarter long versus just one session at their institutions. And we want to also build out additional content for the required courses. So as I mentioned, I work with 3 other faculty at Stanford to create the required content, which I think, like most medical schools, historically has been based on some models of some passive nutrition information that they end up having to find online and a variety of sources, and they didn't necessarily have a lot of faculty support that were expert in nutrition, especially when they get to the clinical level. And so we're trying to take what students identified as the most important things they learned in the Teaching Kitchen elective and put that into a one-time session so that we can at least get all the medical students to have one kitchen hands-on session that covers some basic content. So they'll feel at least they have a little bit more mastery than they do at the current time. As I mentioned, I want to finish data analysis from the 3 sessions we've run and publish that. And also, I'm hoping to get enough time between clinic to just put the entire curriculum out on open source medical education website where people can just download it and use it or modify it however they want without having to pay for anything. It's not a lot to pay for the 2-lane curriculum, and it's certainly cheaper than paying to hire an expert in that content if you don't already have one, but it's still a barrier for a lot of people, and I really hope to get this out to anyone who wants it. And I'm glad that I have this photo in here of our first group of students since the video didn't work, but this is our first class of students in front of everything that they made when they were learning knife skills. So they made a fruit salsa, a vegetable salsa, which covered how to chop a lot of fruit, how to chop herbs, how to chop a lot of vegetables. They made guacamole, and then served it with a lot of healthy plant-based protein, brown rice, whole grain tortillas, things like that. And we also highlight world flavors throughout the curriculum. So I didn't put what we cover in each session in the slides, but this was more of a Latin flair session. In another session, we cover more Eastern Asian flavors, and then we have one where we cover South Asian flavors and give them a mix and match and teach them a little bit about how they compare flavors across different cultural backgrounds. And this also helps us weave in cultural competency when we talk about patient counseling. And so a few brief examples from some of the other levels of medical education are that Loma Linda is one of the only other universities I could find that has created content not just for their medical school, but for their residency program. There are some residency programs in preventive medicine that are also using the 2-lane curriculum, but Loma Linda, I think also because there's a strong interest in whole food plant-based diet there, wanted to create a curriculum that really reflected that. And so their preventive medicine department has 1 session per year for the 4th-year medical students that is required. So they all get some culinary medicine. They have to run the same session 10 times to get through all the students. It's a lot of work. And I mentioned their culinary philosophy. For this, a PhD level dietitian teaches it. They don't have a clinician, a physician clinician teaching it. This is a dietitian who does work clinically. And then they have a physician follow-up session that's 2 hours outside the kitchen that builds on that and explains some of the clinical correlations. So I think getting back to what Anna Maria said earlier, that you can mix and match and do different things based on what type of experts you have in your university and how much clinical physician sort of content you want versus dietetics and nutrition. And their goal was really to increase awareness of food as medicine and not just writing a prescription for a pharmaceutical as a way to treat disease. For their residency program, they do it a little bit differently. They still focus on whole food plant-based diet, and they have 4 sessions per year that all of their preventive medicine and family medicine residents get. This is taught by a joint dietitian chef, so a dietitian trained in culinary arts, and they have a rotating resident teach each of the sessions. So this gets back to more adult learning styles where the resident might not be an expert in culinary medicine, but they have to go and at least learn about the food correlation with some diseases or chronic conditions like diabetes, inflammation, things like that. And the dietitian chef creates and plans the recipes and cooking, and then the resident, together with a dietitian, while they're cooking, talks through the medical education piece. For those of you that weren't lucky enough to get any of these great resources while you were in your medical training, or or you're not a physician, then the longest standing and first culinary medicine continuing medical education offering was started in 2007 in beautiful Napa Valley in California, and it's still running every year. And I know Dr. Delicazio, you present it every year, right? Yeah. So this is not just for physicians, but this session is for a variety of people of a variety of backgrounds. It's not necessarily a specific culinary philosophy as in Mediterranean or whole food plant-based diet, but they go off the see one, taste one, cook one, teach one model. So moving you from being novice to being able to stand up and confidently teach about food and cooking. If you're a physician, you can get 21 CME credits. If you're in nursing or dietetics, you get your equivalent of credits for education. And this is for not just physicians, but chefs, people in industry who really want to increase nutrition, healthy lifestyle in their settings that they're running. Nutrition scientists, sometimes even journalists and lawyers come to the session. So it's a colorful and wide variety group of people that attend this. It's mostly nutrition and culinary lectures, but there is some hands-on cooking, but there is a lot more demonstration cooking. And of course, there's a lot of tasting and wine drinking, networking, things like that. So it's a lot of fun. I highly recommend it. And a few other things that are out there are some large healthcare employers, such as a good friend of mine, Linda Shu at Kaiser Permanente San Francisco, has started and runs what's called the Thrive Kitchen. So this is a pop-up teaching kitchen that they don't have a all the time dedicated teaching kitchen. They have a large conference room and a kind of a roll-in on wheels giant thing that they can demonstrate and teach with a mirror overhead, so that patients, physicians, other employees at Kaiser can learn how to cook and eat healthy, delicious food. Again, the emphasis on the delicious. And then if you really want to do a deep dive and spend more time than a one weekend conference or a here and there class, you can become a certified culinary medicine specialist through Tulane, or if you want to do the plant-based version, that is offered through Cornell. And again, as I mentioned, I leave everyone with these culinary quick tips that are a little bit less news to this group, but are sometimes illustrative for other groups. But just the simple message we teach first and foremost in the teaching kitchen is eat real food, try and eat things that are as minimally processed as you can, balancing out the time, effort, energy, and funding that you have. Eat mostly plants, eat leafy greens, whole grains, legumes, nuts, seeds, and whole fruit. Doesn't mean you can't eat other things, but focus on those and you'll be in really good shape. You could also add plant oils to that list. And then try to lessen these things, so meat, red meat, processed meat, added sugar, processed or packaged foods, deep fried foods, trans fat, and sugary beverages. There are a number of things that aren't on there that are just in the milieu, but have a little bit less consistent evidence for or against them. But this is a really easy message, and I give something similar to patients on a card so that they don't have to be confused by all the nutrition messages out there. And just to get a nod to all the folks that spoke about prenatal and early childhood nutrition. This is my daughter Sage, who a lot of you met, very much enjoying her spinach, blueberry, homemade cashew yogurt when she was learning to eat. So, and I'm happy to take any questions.